Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Agarwal, the president. With me, I have other members of National Medical Associations. I have Dr. Prakash, Dr. Ashraf, Dr. Jamal Chaudhary, Dr. Sanchita, and Dr. Chong. We are going to have two discussions today. One will be presented by Dr. Chong, and one will be presented by me. And then we will have a 15 to 20 minutes of discussion. So starting from the chair, yes, Dr. Gana Bhaskaran is also here.
Yeah.
Yes, Dr. Gana Bhaskaran is also here. He always likes to put his name as Galaxy S9 Gana Bhaskaran.
Yeah.
So because he always wants to advertise Galaxy S9. So I invite Dr. Chong to start.
Thank you, President. Just hang on for a while. I just start with share screen. Good morning to everyone. So could you allow me to share screen, President?
Yes, you are allowed.
Okay, thank you. Okay. So today I just want to talk about some of the lessons we learned from COVID since the COVID infection in Singapore, the pandemic. And right now, as we speak, I'll just quickly reprise some of the figures that you see here. 27,000 cases, and honestly, about 2,000 are in the community. The other 44,000 are in migrant workers. That's a base of 320,000 migrant workers in Singapore. Imported cases, 600. ICU case as of today, 0. 27 deaths so far. And of course, under the resources, we have about 1,000 ICU beds and more than 1,000 isolation rooms in Singapore. So one of the first things that was very important because of our SARS experience was early action and intervention. So the intervention started all the way in 20th January. Started screening at airports, started closing borders to Hubei, to mainland China, and then subsequently to South Korea, Italy, Korea, Iran, etc., and then finally to the rest of the world, including Malaysia, because the Singapore-Malaysia border is a huge crossing every day. It's one of the biggest crossings on earth every day. It's about 300,000 to 400,000 people crossing every day. So there was a big closure. So by 20th of March, we had complete closure of the country. We call it DOSCON in Singapore. It's like DEFCON. You know, you hear of DEFCON 1, 2, 3, 4. We call it DOSCON. And basically, the hospital restrictions, doctors are confined to one hospital, except for ID physicians, infectious disease physicians, and anesthetists. They can run a few hospitals. But everybody else has to be confined to one hospital. Workplace restrictions, of course, business continuity. Everybody checks temperature twice a day, and large-scale events, and of course, contact tracing. At a peak, we had about 4,000 contacts daily by 20 teams, all right? Now, lesson learned. There was a returning wave in March. An estimated 60,000 people came back in a space of 2 weeks from everywhere. And of course, a lot of them did not stay at home as was required by the law. We couldn't monitor 60,000 people. And that's where we had the community and the dormitory spread. Now, then on 25th March, they realized this problem. So they directly shipped people to hotel rooms. So they booked about 8,000 hotel rooms. And then by the time, of course, it was a little bit too late. All right, the spread had already started. Half of those coming back from London had COVID. So thank you, Mr. Boris Johnson. And dormitory situation in Singapore, this is a huge problem we have because we have a lot of migrant workers and 200,000 of them are living in huge dorms, 43 giant dorms, some of them housing up to 20,000 people. And the other 100,000 migrant workers are in factory dorms. So if the top floor of your factory is empty, you just put the people there. That's a factory dormitory. So anywhere from 20 to 200 workers. And there are about another 700,000 workers, which are more highly skilled. A lot of these are Malaysians and they live in the community. All right. So they are not in the dormitories. One of the first things we did when we saw this this problem exploding was we removed those who are 40 and above and those with chronic diseases from the dorms, because these were the vulnerable people. And we had medical posts in the 43 big dorms with police and security and so on. And very important, we ensured that all the salaries were paid on time, 3 meals were given to them daily, and they all had Wi-Fi and SIM cards given to them, 50 gig SIM cards to all of them, so they can communicate with their family back home. So these were some of the lessons we learned. Now, resources, we have quite a lot of ICU and beds, as I told you, 1,000 ICU beds and 1,000 isolation rooms. But yet, you know, with huge figures, we worry about being overwhelmed, even with these resources. We have a new National Center for Infectious Disease. We have an N95 factory here in Singapore by 3M. This is a lesson we learned from SARS. But we still had shortage of transport media, swab sticks, reagents for extraction of RNA, viral RNA, and surgical masks. Because surgical mask was seen to be low on the value chain, so we did not have surgical mask factory in Singapore. And that was a big problem. So today we are ramping up the testing, but the bottleneck remains all these things: the transport media, the swab sticks, the reagents. And we've gone from 3,000 daily to 10,000 daily to 13,000 daily. We hope to hit 40,000 a day. But I think we still have a lot of bottlenecks. And of course, the lab workers and frontline staff have a lot of fatigue because it's now going into 4 or 5 months of COVID. So these are some of the lessons that we learned. Mask. Now, public health measures. Initially, we told everybody not to wear masks, which was, in retrospect, a mistake. But at that point in time, the decision taken then was because we didn't have enough masks to go around. All right. We didn't want a panic and a scramble. So from April the 3rd, we had mandatory masking. And these were not surgical masks. These were just cloth masks issued by the government. So something is better than nothing. And of course, we finally had a lockdown from April 7th to 2nd June because community spread was going up and we had to flatten the curve. There was a Ministry of Manpower punitive measures because at some point, employers were very worried about their migrant workers, wanted to send them to all the emergency units to get the swab done. And of course, we had to stop them from doing that because you'll overwhelm the emergency units. So the Ministry of Manpower put out a punitive measure against employers, which in retrospect, punitive measures are not very good for public health in a crisis situation. So everybody must remember, this is one of the things we learned. And we had the first cluster of migrant workers, 5 of them, in early February. And that was an early warning that was not heeded. And subsequently in April, we had a massive dorm outbreak. Now, these are indicators of performance of how a country or a nation does. Now, Singapore is a nation, but yet it is a city. So a lot of our lessons actually are applicable to towns, cities, smaller cities, and bigger cities, all right? Even though we are a nation, but it's still essentially a big city. So detecting and breaking transmission chains is important, reducing mortality, morbidity, protection of healthcare workers, PPE, and so on. Maintaining food and medical supply chains, very important. Protect and support vulnerable and neglected groups. So we had a big vulnerable neglected group, which was the migrant workers, which blew up in our face. Now, the other group that we're very, very careful about, which could overwhelm our healthcare system, are our nursing homes, our aged care and our nursing homes. So right now, there are a lot of measures in place to stop an outbreak because in that group, outbreak will be different. I'll show you some data later on why the migrant workers did not overwhelm our healthcare system. I'll show you some photos after this. Healthcare system, of course, can maintain its usual services and financial support for individuals and companies, especially when individuals need healthcare, financial needs for healthcare. So these are kind of indicators for performance. by a country, a nation, a city, a town, or whatever. Now, one more thing I want to show you is these are some of the, this is our NCID. We built this National Center for Infectious Disease, and this was just recently built last year and was just opened last year. And some of us commented that it was a white elephant, but honestly, it has paid itself back in spades. 64 cohort beds, 100 isolation rooms, 124 negative pressure beds, 38 ICUs. And the total number of beds can be increased, can be doubled up, because they have a capacity to double up the space if they need to. And of course, there are outside areas where you can build tents and extended waiting areas, screening areas. So this is our National National Infectious Disease Center, which has been handling nearly 60% of all COVID cases in Singapore. So fortunately for us, this came on stream last year, and has paid its way back in spades. Now, this is a slide by the NCID boss. You can see a picture there, Dr. Leo. And this is just a slide to show our experience in Singapore. And
your pictures are not matching. Your pictures are not matching.
Oh, is it? Can you see?
Yes. No, we are seeing on the first slide.
Oh, you're seeing the first slide. Oh. Do you see now?
Oh, because you have shared the presentation, so we can only see the presentation.
Oh, I see. Sorry. I'll switch off the other one. Can you see it now?
No, you close the presentation, so you have to share your screen.
Okay, sorry. Here. Can you see now? Can you all see the slides?
Yes.
Yes, I can see.
Okay, great. Now I'll show you I'll show you again the first slide. This is a slide of our NCID, and you can see it's got 64 cohort beds. This is and 100 isolation rooms, negative pressure beds, ICU beds, and extended areas outside the center that can be used, erect tents, and have extended screening areas. So this is the next slide that is very important. This is the first 1,500 cases in Singapore. And if you look at the data, you can see that those who are 30 and below, the blue bar represents oxygen needs. So only 0.5% need oxygen, and 0% need ICU. If you're 35 and below in Singapore, the first 1,500 cases, 2.2% need oxygen, 0% need ICU. And then the number goes up. The orange bar are those people who need ICU. So for example, 60 to 69, these four bars here, about 36% need ICU and 55% need oxygen. All right, so this is a very interesting data from our NCID. This is another interesting data. This shows the clinical course of the COVID patients. These are, of course, the more ill ones. And they found that the most critical period where we determined whether the patient was going to deteriorate was day 5 to 7. This was the most important period, right? Whether they need oxygen and intubation and so on. All right, so this is another very interesting slide. Now, this is a slide from Dale Fisher. He is one of our professors of ID professor here in Singapore. And this is a slide for how the dorm situation was to be managed. So this is this is a slide that shows you everything: case management, coordination, epidemiology, logistics, community engagement and risk communications, and laboratories. So this is a very essentially a summation slide of what needs to be done for our dorm lockdown. Okay, this is me in the dorm itself, and this is one of our biggest dorms in Singapore. It's 20,000 people. It's called the S11 dorm, and this is the breakup. So all of us were there to sort of like help out in the situation. So I've come to the end of my presentation, and I welcome any questions.
Chong,
So thank you. Can we unshare the slides?
Yes. Yes.
I will also give a presentation, and then we will have question answers, because
Thanks.
so I'll instead of giving complete Indian data, I will give you personal experience of these cases. And for the last almost 3 months, I've been handling cases on phone, telemedicine. Most of them are on telemedicine. And my data basically is data of non-admitted patients, because admitted data is given by the government. And I'm basically talking about the non-admitted patients. So first of all, I like to show you the general figures. India in Asia is on the top. We would like to win an Asian Cup, but not an Asian COVID Cup. But unfortunately, we are winning an Asian COVID Cup in sports. We have over 10 million patients so far, 1 million patients so far. So in 1 million patients, we have 26,285 deaths, which is approximately 2.5 to 3%. And if you see that we are far ahead of China, though we have the same density. So the density of population is same between China and India, but we are way ahead of China. This is something we need to find out, why the mortality in China was so low and how could they control their disease in China. And mortality wise, Asian countries are divided into 4 groups. And if you see here, the mortality of Sri Lanka, and if I say Sri Lanka here.
Malaysia is not here.
No, Malaysia will be here. I'm talking about Sri Lanka here, because they represent mostly Indian type of a representation. Sri Lanka is only 11 mortality and only 2,697 cases. And they are so because why I'm saying is I'm only talking about India with adjacent country. Nepal has 17,000, Malaysia has 8,755 cases. Thailand has more than Sri Lanka. So Hong Kong is lower than Sri Lanka, but Sri Lanka has the lowest incidence and mortality. So what my purpose of showing this is that I will take in Asia the lowest mortality which is achievable. So I'm going to say is, therefore our aim should be that of Sri Lanka for India, and for Hong Kong and Singapore, it should be their respective countries. If Sri Lanka can achieve it, then why can't we? The India, Afghanistan, Pakistan, Bangladesh, Nepal, why can't we achieve that? If Australia and New Zealand can achieve it, why can't we? That's my question. So my question is not that this mortality, I cannot accept that the mortality is high. So I am going to present you some of the data which I have been able to collect. No, this I have to go up by. So we have divided children into 2 groups, less than 12 and more than 12. Children, we have found they are not the first one to get infection. So if there are 5 members of the family, all 4 of them have got infected, then the child will be spared. And if all 5 of them will be infected, child will be the last. The average duration of symptoms we are finding 3 days in children less than 12 years age. The commonest presentation in children in India is rash, diarrhea, fever, and cough. They are often spared in the family, and we have no evidence to say that they spread infection to other children or to the parents. We have seen hypothyroidism, diabetes rate is the same whether you are a COVID or not COVID. So we cannot say that hypothyroidism you have more chances of infection, or in diabetics you have more chances of infection. Rash we have seen in 2% cases anywhere in the body. Headache, persistent headache, unusual first onset 2%. 10% of the cases we have seen exertional shortness of breath with no fall of SpO2. Most likely this is smaller airway obstruction. Most likely this is smaller airway obstruction. Exertional SOB. Then we have seen in 10% of the cases diarrhea, 60% are female, and the consistent finding is a common toilet. So therefore, we will come back to public health important. Loss of smell and loss of taste we have seen in 20%. Hemoptysis in 2 people with negative CT. That means they may have a bronchitis which is causing hemoptysis. This is with negative CT. Cystitis, COVID cystitis 1%, COVID left eye conjunctivitis 1%, vertigo 1%, right iliac fossa pain like appendicitis 1%, toothache 1%, nose block alternating irregularly. He says sometimes my left nose is blocked, sometimes my right block is concerned, is 1% each. Throat pain, irritation, and feeling of obstruction in the throat 60%. Fatigue, tiredness 12%, which is episodic. Pain below the knee, specifically 10%. Feeling of warmth in the body 1%. Sweating unexplained 1%. Swelling of face and leg 1%. These are unusual features. Then we have divided our patients into 9 days and after 9 days, because of the evidence that on 9th day, the virus becomes non-culturable, non-replicative in non-ventilated, non-immunocompromised patients. We have seen throat irritation in 30% lasting for more than 2 months. Evidence of bronchitis lasting for 2 months. Exertional tachycardia lasting for 2 months. Episodic tiredness and weakness, 15%. They say, I'm okay today, tomorrow I'm tired. Low-grade fever, exertional, evening rise in 10% of the cases. Costochondritis in 15% of the cases. These are post 9 days. So these are, I call them as a post-COVID. They are the people who otherwise are healthy, should go to a non-COVID facility. Positive RT-PCR on 14th day. Normally 14th day PCR should become negative. 7% of the people we have seen, they are persistent RT-PCR, non-admitted, non-ventilated, non-immunocompromised people, and their mean RT-PCR lasts for 20 days. Then we have seen loss of smell and loss of taste. This is a data of 100 people we gathered together, all of them in one meeting on a Zoom. We collected 100 patients with loss of smell and loss of taste. And this, they had only 3 of them had mild pneumonia. Oxygen requirement 0, ventilator 0, death 0. Menstrual improvement in 2. Children were 7. Children means more than 12 years of age. Fever was present in 14%, predominantly male. Ear involvement was in 70%. Predominantly, they said something is some minor symptoms in the ear. All family members in 4. That means everybody in the house had the same symptoms. Costochondritis in 15. Smell and taste both gone 88%. Only taste gone 7%. Only smell gone 5%. Most of 98% of them have preserved taste of sour, but 2% said even sour taste has gone. More than 4 weeks, it lasted in 1. More than 3 weeks in 3. Most of them recovered in 3 weeks. After 7 days, it appeared for the first time in 3 people. And most of the people, it appeared. Now, this is the data of patients where the fever is lasting for more than 2 weeks. That means this is a post-COVID fever. This is either a thermostat dysregulation or it is a high CRP, high PCR persistent inflammation. More than 50 days 2, more than 40 days 2, more than 28 days 2, more than 21 days 1, more than 14 days 7. So these are the number of cases. When I say number of cases, mean this is all percentage. Then we come back to IgG levels have started only in the last 2 weeks. We have seen higher IgG concentration in people who have pneumonia, more in adults, low in children and elderly, low in less loss of smell, low in people with loss of smell and loss of taste, low if the fever is less than 100, and it is still present in most of the people who are antigen positive. That means antigen positive is a dead virus, not a living virus. We are recommending 5 things for screening. Most of the people are screening temperature. So we are recommending that if you want to screen a patient in the OPD, do 5 things. Temperature screening, if the temperature is low grade, because temperature does not respond to acetaminophen or paracetamol. So this can be used as a screening tool. SpO2 levels to pick up happy hypoxia. Give them, test them for loss of smell by giving them a rose to smell. Loss of taste by giving them a jaggery, because the first one to go is sweet. And then a hand grip strength. So if the hand grip is less than 35 lb, you know that person has a weakness. So these 5 we are recommending as 5 tests at screening instead of only screening for temperature, because temperature is not present in all. We have seen that we have wave 1 has gone in Delhi, Mumbai, Chennai, and Ahmedabad, and now it is appearing in Bangalore, Hyderabad, and Pune. And wave 1 in India is related to joint families and closed colonies. In Singapore, you have seen a close cluster of people, but in India, there is a cluster of people in every house. So those people who are joint families, 9, 10 people living in the same house, in the same floor, all of them now practically developed the disease in terms of families. Therefore, our first wave in Delhi, Bombay has gone. But now the nuclear families will start getting it. We feel that instead of a complete lockdown, personal lockdown is the answer. Personal lockdown is, I am responsible for my health. I will not allow anybody to enter my vicinity of 6 by 6 feet if he is not wearing a mask. We have seen antibodies in Delhi in more than 20% of the cases. That means in Delhi and Mumbai, the seroprevalence is 18 to 20%. The death rate in Delhi, therefore, if we take antibody prevalence into consideration, it is less than 0.3%. It has, over the last 1 month, the mortality in Delhi and Mumbai has reduced by 50%. That means standard protocols and early diagnosis is reducing mortality. Day 3 to 6 are the most important. If you are a non-pneumonic COVID, you have a very low risk. If you have a pneumonic COVID, then day 3, 4, 5, 6. If you have exertional tachycardia, exertional low SpO2, exertional cough, or exertional difficulty in talking, you take it for granted you have pneumonia. And on day 3, if you give them steroids, if you give them antiviral, and if you give them low molecular weight heparin, then mortality will be an exception and not the rule. AII rooms in India is still not present. That's very unfortunate, because government is still not thinking of making AII room compulsory in every hospital. We don't have a data. The labs are still not giving CT value of a RT-PCR test, because if the labs start giving a CT value is a current cycle threshold, and lower the value, higher the viral load. And if that becomes a mandatory, because every lab can give, they have the CT value, you will be able to isolate and treat and manage the doctors. Because if I have a patient with a very low CT value, with a very high viral load, doctors needs to be very, very careful with that. I'm now analyzing the death data of around 100 people who have died. And the currently I'm finding is that most of the people who have died, there is a delayed reporting. They are missing day 3, day 4, day 5, day 6. If the presentation date is, if you are presenting in the hospital on day 7 or day 8, mortalities are very high because by that time your pneumonia has already complicated. When we talk about transmission, because of a very high density population, we should go for a 0.3 micron mask, whether or not person can afford. Our recommendation has to be a 0.3 micron mask and not any other mask for the public. We are seeing a large number of toilets becoming a COVID chamber because they are absolutely airtight, no ventilation, not even a small button to see inside because of privacy. And most of the time their exhausts are not working. So all the families, we are getting multiple people in a family. The common finding we have got is a common toilet. Closed, ill-ventilated rooms is the wave. In whichever city and country you have a closed, in-ventilated rooms with more than a large number of people staying together, that will be the first wave. Contact time in a COVID chamber is 5 minutes, in a non-COVID chamber is 10 minutes. So therefore, our contact time definition of 10 to 30 minutes should revise if you are in an ill-ventilated room. And then we are defining COVID into 2 phases, a 0 to 9 days, that is a COVID phase, and 9 days post-COVID phase. A post-COVID phase needs to be treated like a non-COVID patient. Thank you. Because I am the speaker and because Dr. Chong is the speaker, so I will request Dr. Ashraf Nizami to chair this meeting. Because I can't chair, I'm a speaker. And similarly, Dr. Chong is a speaker, so Dr. Nizami to chair this meeting. He is the first Vice President of CMAAO.
Thank you very much, Mr. President, giving me this honor. I believe both the presentation, especially from our Chairman Chong, and I believe that this is the leading city, as Mr. Chong himself he said, that still it is a city, Singapore, although we believe that it is a great nation over there. And Dr. Agarwal, adjacent to Pakistan, and the criterion in Bangladesh, Pakistan, and India, and up to the Sri Lanka, we have certainly the same sort of problems or issues. And I think that we can have some questions if the colleagues, they want to ask any question. So questions should be welcome. Anybody? Questions, please, if you can listen me.
Dr. Jamal.
Yeah, thank you. Actually, I was just thinking to ask you that in the Bangladesh, actually, the mortality rate is just above 1%, 1.35%. And I have seen in India, it is 2 point something. So how do you explain this actually? Why actually it's like this actually? And in Bangladesh, actually, ICU beds are empty. We are just afraid at the beginning that we'll be scarce in terms of this number of ICUs at the beginning. But now our ICU beds are empty. Actually, less than, you can say 40% used like that. And our hospital beds also are going empty. So the people are taking oxygen in the house probably, and which is not encouraged, but still they are going on. So how do you think this as a better intervention?
I personally feel is the mortality of this virus should not be more than 0.3%. All over Asia, in Asian countries, in Delhi, in India, Pakistan, neighboring countries with the same type of a race, including Singapore, and because the same race we have presentation in India, our mortality should not be more than 0.3%. For every one tested patient, there are 20 untested patients. For every one patient, see, remember, people, the number of data in our country is not to be believed. The reason being, we are diagnosing patients only by cough, fever, and breathlessness. Majority of them do not develop that. They develop diarrhea, loss of smell, loss of taste. That criteria has only changed recently. So therefore, you will be missing large number of cases if you are using WHO criteria or if you are missing a CDC criteria. So all those cases who presented with loss of smell and loss of taste till last week were missed in India. They were not included in Indian definition because the definition was different. So you cannot believe the data of anybody in the world unless, because now it has to be a clinical data. So when China wanted to do on 12th of February, they wanted to bring the data of a clinical data. WHO refused, only go for investigations data. I think we are doctors. We have to treat the patient and not the investigation. So therefore, for the chronic, the term CLI, this is corona-like illness, is much more common than expected. So in a 80, if I talk to 100 people, 80 of them are CLI, only 20 are RT-PCR positive. CLI means, so they are having the same typical symptoms. Either they are corona negative or they don't want to get to be tested. Everybody can't be Amitabh Bachchan or Aishwarya Rai Bachchan that they can go for a second repeat test and that turns out to be positive. So here negative means negative, which is not correct. 50% of the antigen test is negative and 30% of the RT-PCR is negative. So clinically, 80% of the cases are CLI, which is corona-like illness. Clinically, we have to treat them as corona. See, the positive negative has a public health importance, not to us. I can't say a patient that because you are corona negative, you are not infectious to me. No, for me, even CLI is infectious to me. So therefore, that direction of the WHO, positive negative, has no value. We believe more on CBC, ESR, CRP than on the RT-PCR positive or negative. I mean, in fact, the first test I order them is because the first test I order is CRP, ESR, and CBC because I need to pick up a serious CLI. I'm not interested whether it is positive or not. If there are 6 people in the family, they are living together, all 6 of them are having the same symptoms, 3 turn out to be RT-PCR positive, 3 turn out to be RT-PCR negative. Am I going to allow them to mix in the people? No way. For me, they are positive. They are false negative.
May I have another question actually?
Yes.
This is actually Bangladesh is considering to introduce the antigen test. So you are telling it's 50% sensitivity. So they are claiming that if it is coming from the European or American origin, so that they are claiming it is more than 90%. How it is possible when RT-PCR is only 67% sensitive? In that case, our antigen is higher. What do you think?
You're talking about specificity or sensitivity?
No, sensitivity, not specific.
You're talking, see, if antigen is positive, it cannot be false negative.
Yeah, that's okay.
But if antigen is negative, it can 50% be false positive.
50%. But in Bangladesh, some companies, they're claiming that it's 90%. How it's, that is I'm telling you.
Is it a claim?
So,
no, it's a claim or a proof. There's a difference between a claim. If you say,
I don't know actually whether it is like
see, Jamal, there are 2 terms, either claim or second established. If you say it is established, it's a it's a very, very, very breakthrough test. But if you say they claim, even I can claim today that I am not going to get corona in future. I can claim. If I get it, so what? Right. Claim is a different issue than if you say that it is tested and it has been verified, this is fine. This will be a breakthrough. They will be the leader in the world. If that company proves that their test of antigen test, is it a blood test or a swab test?
It's it's blood test.
No, blood test antigen is, then they are talking about IgM. Then they are talking about IgM. IgM will come positive after 7 days. Yeah, that's a different issue altogether. Blood test is nothing to do with antigen. It is IgM, it is antibody. Blood test cannot detect antigen.
And
Then it
now,
is a IgM antibodies which you are detecting, which is people can claim, because now it is not yet been verified anywhere in the world about the IgM data. IgG data is just evolving. So if you are doing in India, we are doing a swab antigen, not a blood antigen. Swab antigen in India, we have not been able to get a sensitivity of more than 50%. That means nowhere in the world a sensitivity of more than 50% is available.
President,
Okay, can I? Hello.
Sure.
Yes.
Chong,
President, can I say
Mr.
something?
Chong, yeah.
Yes, yes.
Thank you, Chair. So what happened in Singapore was we actually have a lot of these antibody kits coming from China, April and May. Our task force used these kits that were coming from China, and on the average, we found that the detection was about 30% sensitive. So very, very disappointing, these antibody kits that have come from China that were sent to us. So I think we also found that if you wanted to detect the IgM and IgG with a certainty like close to 90 to 100%, usually it'll be way after. It'll be like 2 weeks after the infection. So it'll be like day 14, day 15. Then you might get 80, 90%. So I hope that helps. Thanks.
I want one question which I am not been able to answer myself. What part of the virus is causing the illness? Is it only the spike? Do we have an evidence that only the spike of the virus is causing illness and nothing more? That non-spike portion, because now we are talking about only, everybody is saying spike vaccine, spike antibodies, spike antigen. So you are detecting only spike antibodies. So that means other portion of the virus is not.
मुमताज, तुम पहले इस्त्री कर देती ना, लाइट चली जाएगी. गड़बड़ ना हो जाए. खाली
Yes.
If you are concentrating
Yes, sir,
only on
kindly
the spike,
mute yourself.
if you are
I thought-
only checking the spike, because most of these tests are spike antigen. So
Yeah.
therefore your reliability cannot be 100%. That means non-spike portion of the virus, see the virus from Oxford, vaccine from Oxford is only the spike portion. So therefore it will prevent spike complications. So if there are non-spike complications, Oxford vaccine will be a failure. So therefore I because I am not clear, I'm not been able to get the evidence that what is the RNA disease, what is a membrane disease, what is an envelope disease, and what is a spike disease. It can't happen that the whole virus and what kills what, because maybe that if this you are testing RT-PCR, your persistence of RT-PCR means what portion of the virus it is detecting. So that way it is causing concern in my head. If you have any experts in your respective countries, call next time for a deliberation. Because when we talk about sensitivity, specificity, we are only talking about, so therefore we need to see in an antigen test or antibody test, which antibodies it is talking, which antigen they are talking, which vaccine they are making. If you are making vaccine only of a spike, that means it will produce spike antibodies. It will not produce viral antibodies. And unless you say spike is the only virulent in the virus, I have not come across any study which says that the non-spike portion of the virus does not kill. That's my question. That's disturbing me, and I'm not being able to get the answer.
I think it is still in a scientific process, and people are working as the Oxford or the UK and the Chinese colleagues, Canada, Australians, they are on the humans, and I'm sure the such questions which has been raised by President Agarwal, you will get the answers definitely, I'm sure. Chong, you should add something.
Yes, I think this probably will have to go and talk to the virologists. There's a group here in Singapore which works for Duke NUS, Duke University collaboration with NUS. So probably have to go ask them exactly what is going on there. They've found neutralizing antibodies. They did some studies and they have developed a test kit that looks for neutralizing antibodies. So you know and I know that when a virus enters the body, right, you have 1,000 different type of antibodies. The one that is important is the neutralizing antibodies. I probably need to go and have a conversation with them.
Okay. So, Dr. Nizami,
Right.
you can ask everybody
Yes.
to speak.
Yes.
Yeah, anybody? Any question or comments, please?
Yes, yes, Dr. Kaiser Sajjad.
Dr. Bhaskaran.
Yeah, Baksan.
Dr. Bhaskaran.
Hello?
Baksan first. Yeah, please continue.
Dr. Bhaskaran and then Dr. Sajjad.
Okay, thank you
Yeah.
very much. I think it was a very excellent discussion going on. Dr. Chong, congratulations on the white elephant, but now it is useful. Singapore always does something ahead of everybody else. Now, coming back to India, there was a very detailed explanation by Dr. Agarwal. Well, we all are surprised that, though despite the fact that it's been 4 months, we don't have clarity on the antigen antibody test kits and all that. We are also having problem in Malaysia. But fortunately, our numbers of COVID infection has been really, really good. In the sense it has been kept under control. It is about 8755, and then discharge was 8541. The death rate is still 122 for the last 20 over days. We had a single-digit infection for the last 20 days, but unfortunately, in the last 2-3 days, we have been seeing double-digit. These all are clusters from people coming overseas, not from the local thing. Local is very minimal. But I think we are still waiting to see how the 2.1 million illegal workers, immigrant workers, and 2 million legal workers, they have not been tested completely. Only 35,000 or 40,000 tests has been done on them. So we do not know where we are heading for. We have not seen a second major cluster yet. Thank you.
I'm interested in one data which people can give me and send me in the WhatsApp group or send me next time. What are the number of joint families in each country vis-a-vis nuclear families? Because I'm sure that people living in joint families in various countries, whichever country you have a joint families, the first wave will come there.
Right.
Dr. Sajjad.
Okay.
Can we listen, Dr. Sajjad? Yeah, Dr. Sajjad,
Yes.
please.
Yes, I'm Dr. Kaiser Sajjad. Thank you very much. I'm sorry that I joined late, little bit, but I joined Dr. Chong presentation. That was very informative about the Singapore, and also the presentation of Agarwal was very informative. But I just want to share or give my experience regarding what the Agarwal said about the loss of smell and loss of taste, 5% and 7%. But I think here we in Pakistan we have a little bit upper percentage of loss of smell and loss of taste, little bit, maybe 10%. And the ear, we don't have any ear complaint, associated complaint with the COVID. Maybe this is a patient's sharing that sometimes patient have some problem of ear and something, but that is not because of corona in all. Maybe 1% you can say the patient say that they have some ear problem, there is blockage, there is some simple twitching of the ear or something. Lastly, I have an observation that my suggestion in Pakistan also, that if somebody have the PCR positive, then don't go for the second or third test. We advise them to don't go for negative. Just stay at home, go follow all the SOPs or the preventive measures, so that you just complete your treatment or whatever the SOPs are. So this is our advice, that never go for the another test if you have a positive. If you have a negative, you are unlucky, and if you are positive, then you are lucky, and just proceed accordingly. Thank you very much.
Yes, Sajjad, our smell
Thank you
and
very
taste
much,
is 20%.
Kaiser.
Smell
thank
and
you.
taste
One thing
loss is 20%.
one thing I would like to share, that there is the research, there is the clinical management of to the COVID patients. These are entirely different. And what Dr. Kaiser Sajjad has said, that not going for the testing, it is our socio-economic issue. The economical issue is entirely different from the research and so on. And the research is based on the investigations, with all my due respect to the president and Dr. Sajjad, that the research has to be based on the investigation. And once we have to think of, and hence it is a new disease which we are not clear about it, that how it is going to behave, it is behaving very differently. Here in Pakistan, it is going very down, but it is the down clinical what I feel over here in Pakistan, because we have a very low testing over here in Pakistan, and we cannot claim that these are the patients who are coming with the COVID affected, whether they are the 90% or the 5 and 6% where we get the investigations and clinically they need certain support by the hospitals and the health establishments. So this is what I believe. It has to be addressed in this way. Yeah. Anybody? Any questions or comments, please?
I have just question to Dr. Ganavaskar. May I have?
Yeah, please.
Yeah. Would you suggest anything for Bangladesh, India? Although not feeling that we have already missed the train, but Malaysia has contained a lot actually. Could you please suggest something which at this stage you can take the measure to curtail or contain the infection? Dr. Gonavaskar, from Malaysian aspect.
Yeah. Bhaskar, I think he has left, or
he has left.
I can't see him on the screen. Yeah.
So,
but
so
I think I
no,
share Mr. Jamal that we
can I just ask you also one thing? That just actually at the beginning we had a SARC meeting actually, SARC meeting. This is interministerial. No, this is actually inter-DG level meeting. It was. I also participated in that first meeting, and then it has not proceeded actually. So actually, in Pakistan, Bangladesh, and India should think together what else we can do now. Actually, we have to think about this life and this infection and others together. That has to go together. We cannot tell all the people that you have to be in quarantine, you have to be in a lockdown stage all the time. So it is a question, a different issue in this subcontinent. So can we just think of it, that how we can contain this, and what other measures we can take, rather than fully locking down? Yeah.
Dr. Nizami, can I answer this?
Yeah, sure. Why not? Yeah.
In India, in Pakistan, in Nepal, we have a high density population. We have joint families. So our problems are different than others who don't have joint families. If you are going to do a lockdown today, it is going to be wrong. The reason being, you are shifting people in their home. Even if one of them is positive, he will infect others. Lockdown was possible initially when the infection in the country was not there. If there is already a widespread infection in the community, you need people to be out of the house and not inside the house. Because inside the house, if 10 people are there, even if one is positive, all 10 of them are going to become positive. So the answer today is personal lockdown, not a national lockdown. Whenever your disease is prevalent in a society, you need a personal lockdown, that I need to protect myself. Everybody has to protect himself or herself. So therefore, you need to use a mask at home. If you are not using mask at home, and if one of them is positive, all 10 of them are going to get affected. So therefore, I say that strategy has to be different from joint families and nuclear families. You can't have the same strategy for 2 people having big house, only 2 people living versus 10 people living in one house, in one room set. The strategy has to be different. I am 100% sure that all those countries, the incidence is low because they are nuclear families, they have big houses, they can maintain a social physical distancing at home. They are not with each other for most of the time. But in India, where 10 people are sitting in one room, in one drawing room, sitting together. When they are watching TV, there is only one TV. So I have 4 people in my house, I have 6 rooms, and I have 4 TVs. Nobody sees TV in the same room. 2 of us don't see because everybody has their own preferences. So everybody has a big TV in their respective drawing room, in their respective chamber, and they see. So my chances of getting infection is delayed. But if all of four of us are sitting in one room in a congested room watching TV, they're going to get infected. So therefore, the strategies have to be different. India, Pakistan, Nepal are different because we have large number of population living in a small rooms. We believe in joint families. Right now, if there is an India-Pakistan match, everybody will forget physical distancing, and 20 people will be sitting near the television for hours together. They won't care if I get my virus or not. So India, Pakistan, we countries are different. We have high density problem. So therefore, in a high density, how will lockdown work? If you are locking down, you are you are basically producing a chamber in the house. No, take them out. Lockdown is not the answer. Personal lockdown is the answer. I need to protect myself. Therefore, at home, if I can't protect myself, I'll wear a mask. That's what I say very clearly. This will not be true. This will not be true for nuclear families, and this will not be true for Hong Kong, Singapore, Korea, because they have a different problem. They have a big houses. They have enough place for a physical distancing at home.
I just can I just tell you one thing? Actually,
Yeah,
I was advocating this in Bangladesh, and I talked to the media also, several medias, but nobody is caring for this. Actually, you know, in Bangladesh, actually, it is a bit difficult in the sense that you have already mentioned that is a crowded housing, crowded family, and one other thing is that the humidity is high, and the people outside, working people, they cannot keep actually this mask in their face. So that is also issue actually, and they did not want to do that, and they do not comply. So these are
Outside,
the things. Yeah, outside
Jamal,
also. Yeah.
outside the house, why do you
Agarwal,
need a
may
mask?
continue
Why do you
because
need a mask?
Agarwal,
Yes,
just second,
continue.
please.
Ashok
It is a good debate. It is a good debate. I understand, and certainly Agarwal, our president, he has his own point of view, and he stress upon his point of view as far as this region is concerned. But there are certain, I think, basic principles and rules when we address the spread of any virus or any disease or what is going to happen. So we have to follow those rules, I believe, and spread of the disease, only the system which is the universally now it has been accepted, that is one of the system is a lockdown. No doubt in Pakistan now people speak about smart lockdown, regional lockdown, and hence there is Dr. Russell is there and he will bear me out that how it is happening in Australia. Those countries who are considered to be developed countries are more or less literate, civilized, but it is there. And the question is only the communication and the interaction, integration which happened over there. And they were being compelled to the lockdown. But certainly, I agree with Agarwal that it cannot be taken for granted for any region or any country. And there has to be certain their own principles or the decisions. So not going to be indulged in the, if any word by Dr. Russell, we would love to listen to you.
Well, I think what Dr. Agrawal said, I mean, there is a difference in terms of his family. Now, Australia, it is different. We have, there's no very, except where the cluster came, we've had a problem. You might be aware that Melbourne is going through a phase now, and we have a lockdown to stage 3, maybe even stage 4, but yesterday it came down. Now, there is housing, what you call public housing, which a lot of migrants and the lower socioeconomic group of people are there. And that's 3,000 was built, I think. And that has happened exactly what they had to lock those places down. And there were more than so many, 10 people or so in each of those, what do you call it, apartments. And so they were put not just in lockdown with police and so forth, they couldn't even come out of the house. And now they've kept one place. But overall, I think the important thing that we learn from what has happened, 3 states are, you could say, virus or free or in Australia. Only Victoria and New South Wales still are having. Victoria had and that's a very interesting thing because about maybe a month or 2 months ago, the quarantine the quarantine that was happening, they, you know, where here all people returning were mandatorily put in hotels, which the state paid for, 5-star hotels, but they had a security, and for some reason Victoria did not use, the other state used the defense, but they used contractors for security, and there was a total flaw there in which the contractors, I don't know what the real story is, but certainly they went out with they went along with the quarantine people, and now there's a judicial inquiry taking place. And in the process, they took back infection to their houses, and this suddenly flared up. And you can see once it's set in, it's been so difficult. They have, yesterday we've got, they are doing in Victoria alone 35 to 40,000 tests every day. Yesterday was 38,000. And what they found yesterday, in fact, I was listening to Mukesh Agarwal's, he's got one of the Commonwealth centers. But what they're showing is that now everyone are being tested, and more than 20% are symptom free. They're coming, all have been asked to test whether they've got symptoms or not. And that's brought in another look, a group of people who were probably not having any illness now because of this pockets, certain areas, northwest. All the people are being tested now. What happened was, prior to this lockdown, about a week or so or two before this, as it was building, a couple of people went to New South Wales. Now they have ring-fenced Victoria or Melbourne off. Melbourne from the country is also ring-fenced, so you can't even go to the region in the same state. Now, what happened was, in this short period, it has transmitted to New South Wales. Now, New South Wales, from the last maybe 4 or 5 days, they have had, and they've done genetic sequencing to look at that's what they're doing now to trace back where did this the infection come, the family of infection from the same person, and they actually linked it back to Victoria. Now that's led to another problem in New South Wales, and so we've got two districts in New South Wales have been ring fenced. They have been blocked off. They're not allowed to go, and of course, you're not Queensland. All the other states, you're not allowed to go. Everyone's locked off, and so there's a big worry now. Yesterday they brought in new rules in New South Wales, again restricting hotels, and we were all opening up, and in the process this came. So after seeing this, all have become scared now, and so New South Wales has had this transmission starting there. So from yesterday, I think from today, they brought down, you can only have 10 people in a restaurant, bookings, not, maximum of 100, and a lot of things they have brought. Victoria, of course, Melbourne has got the stage 3 lockdown, but the rural power is not, only one place has got lockdown, the rest of the places are not. But you can't go between metropolitan and rural, there's police. And now that's, I heard Dr. Chong, what he said about enforcing, that is true. Public health, it should not be, but unfortunately, now here the police, defense, all of them have come out. And of course, in the big picture, we still have only 108 or 110 deaths. And even which we are now in such a bad state, there's 29 intensive care beds that are being used. So it's not, the system is there, the health system, that's only in Victoria. We have got 29 to 30 beds, that's all that have been used. So, but they've taken it, in a war footing type of thing. That we've had defense, I think more than 1,000 defense people have come in, medics have come in, they've taken over some of the testing, some of the, even the ambulances. But we've had another important thing is that medical, like the rest of the world, I think around 150 health professions have now become positive, and that's not yet causing workforce problems, but together with that, there are isolation. So that's another concern that's come up, like we've seen in other places. So in a very small way, of course, you have the resources here, and you have basically a very good, well-funded, good health system. So these type of things, will probably transcend. And as Dr. Chung put out, I saw a lot of good things. People do have, the what they call job keeper, and there are so many supports for people so that they're not put into too much of distress from the other side of finance and so forth. So those type of things, what's happening
Thank
here.
you very much,
So,
Russell. Thank you. I think we are now running short of time. I
Sure.
see only a single lady over here, Dr. Sanchita. If she wants to share something, otherwise I would like to hand over my chair to the president. Sanchita,
Just,
would you like
just,
to share?
Mr. President, can I just propose one
Jamal,
thing?
Jamal, we are
Just,
running short of time. Just
no,
the other part, Jamal.
just one. No, just one thing.
Kindly listen to me, Jamal Chaudhary, just listen to me. We are just listen, please. Just listen. Let's we have some point of view of our honorable lady. She's Dr. Sanchita. I have requested her if she wants to have any comments. Otherwise, we will be just 2-3 people talking about. Yeah, Dr. Sanchita.
No, sir, I think I've been listening to you all and learning from you all. So
okay,
nothing, sir.
She's our group
Okay,
editor.
okay.
She's compiling all the data, and she's circulating every week the data which we are discussing.
That's great. I
Next
appreciate
speaker,
it. Anyhow, it
next
was
month.
my honor to ask the honorable lady who is participant
Absolutely.
over there and certainly the
So
comments.
thank you,
Yeah, Jamal,
Dr.
you want to ask
thank
any
you.
question? Dr. Jamal is very,
just actually just thinking that whether we can suggest our governments to take a common actually dialogue, uh, having a dialogue on this issue. Actually, we are facing serious issue actually now. It's spreading day by day. So can we have some sort of this sort of meeting that which you started at the beginning? It's not continuing.
So
Can we
there
just look at our
Dr.
Jamal,
government?
may I respond? Yeah, I respond to Jamal kindly. I appreciate Jamal. I will appreciate if you give a presentation on the coordination between the neighboring countries. Although this COVID-19, that has dropped all the borders. There are no borders for the COVID-19. So globally, we have to come up on the decisions and the follow-ups what the international community is saying about. But I agree that hence we have to speak about our region. And I'll appreciate if Mr. President will ask you or request you to present the cooperation between the SAR countries or the countries likewise, and you find something that race and so on have some importance over there. So I think then we can have an open discussion on this, and certainly as medical association, to my belief that we have to act and put some pressures on our governments for health and communication, that the health professionals, they have to come together for the betterment of the community, for the ailing community, and certainly at large for the people of the globe and people of the region. I agree, Jamal. So in the last, I would just, as I was been honored to be the chair, it is my, I just want to appreciate Mr. Chong, the chair of the CMAAO, for excellent presentation. And as far as we here in subcontinent, we look your Singapore as a leading in health and other progress, what is happening in our region. So I appreciate your efforts, appreciate the efforts of the government. And I have also the same belief that the writ of the government has to be there. I appreciate when with the medical professionals, the policies there, law enforcement agencies are there. I think that is the only way when there is any pandemic or epidemic situation and where people don't want to listen and don't want to understand. I'm again thankful to Agarwal for his efforts, for his communications and excellent presentation, what he has made about the regional and the Indian perspective about it, and the scientific, what he has an idea and prospect about the vaccination. And so I think it is all ongoing process and it will be. And last but not the least, I would like to say as a chairman that the only way to progress or to control the disease, it is the people and the state or the government, they have to be on the same page. until and unless people and government or the state, they understand that they are not on the same page, it is quite difficult to control the pandemic what we are facing nowadays. So thank you very much to all my colleagues, friends, for their comments, discussion, and the discussion. Now I hand over to Mr. President Agarwal, please.
Just few couple of announcements. Next topic we will discuss in detail about Bangladesh problem. Let Bangladesh present and let him write down to every association who are present here. So we can come back specifically Bangladesh problem we'll discuss as a case study next time. Dr. Jamal will be presenting the data and there will be a discussion of what can be done in a state like Bangladesh. Next Saturday, 2 weeks from now, I want to divide CMAAO into 4 groups. So I want one group is India, Nepal, Pakistan, Sri Lanka, and Bangladesh. That data I will be presenting, taking help of all these countries. Then Dr. Ravi Naidu will present on Malaysia, Indonesia, and Thailand. He will combine these 3 countries together. Dr. Chong and Dr. Alvin will present on China, Taiwan, Singapore, Korea, and Hong Kong. That means 2 of you will decide the countries like that. And I will have somebody prepare, if Dr. Pillai can prepare for the Arabian countries who are not our members, but they are part of the Asian countries, because their mortalities are very high. So we will divide Asia into these 4 groups and try to find out common factors, it's more like a research activity. And a week after that, we will compare ourselves with the Europe, with other countries, other European and other countries. So let's first find out what is common in Asian countries. So Dr. Chong and Dr. Alvin will be responsible for China, Taiwan, Hong Kong, Singapore, South Korea, and China. That data we need to pool that data and see what is common, what is not common. Dr. Russell will have New Zealand and Australia. Either he speaks or he identifies somebody from there. That will be Oceania part, that is Australia and New Zealand. I will take care of India, Pakistan, Bangladesh, Sri Lanka, and Nepal with that. And Dr. Ravi Naidu will take care of Malaysia, Thailand, Indonesia, and any other neighboring countries they have. So we will be able to divide, and then we go back to comparing ourselves with other countries. Thank you very much. And let's start preparing for our respective, because that will be a really good data to compare and come out with some positive findings. We'll see you next week, and Dr. Jamal Chaudhary will be the speaker next time. Thank you.
Thank you. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Thank you.
Bye-bye, Dr. Nizami. Bye-bye.